Welcome, everyone. Thank you for joining us today. Okay, I think a few folks are still coming in from the waiting room. We'll get started in just a moment. So welcome. Thank you for being with us again here today as we look at shortages to solutions, reimagining oral health workforce policy as part of our Rural Oral Health Seminar series. We're so glad you're here with us today, and we're really thrilled about our speaker and excited to dive in. We can go ahead and go to the next slide. I'm Liz Flannery. I'm the Director of Education and Leadership here at the American Institute of Dental Public Health. I'm joined here with my colleague, Shayla Stewart, and our presenter here today, Bridget Walsh. Again, we're thrilled to be with you. I'm going to go through some quick housekeeping and overview before we dive into our presentation. So again, we're going to do some housekeeping here, and then we'll hear from Bridget Walsh looking at reimagining oral health workforce policy. We'll have Q&A and time for discussion. We really want these seminars to be as interactive as possible. We want to make sure we hear from you and get your questions answered. So if you have questions as Bridget's presenting, please share those in the chat. I'll be collecting those and making sure we get to them. Again, we'll have some dedicated time for Q&A, but we want to hear from you as we go throughout. With that being said, we can go ahead to the next slide. Say a thank you to our partners and head to the next slide. And just some quick housekeeping pieces. We are recording here today. We will have our recording available via our Academy with CEU information after this session. And I want to invite all of you again, with it being an interactive session, if you are able, please come on camera. Limit your distractions in your environment so you can engage and participate in our interactive portions. And I also ask you to type your email and organization in the chat to introduce yourself and get started with our conversation. We can head to the next slide. Just a quick little overview of who we are as AIDPH and why we're here with this seminar here today. We are a 501c3 nonprofit, and our mission is to empower our community to advance oral health through science, education, and advocacy. We do this work because we have a vision of a justice-oriented oral health system. And if we go to the next slide, we'll see that we as an organization have 4 communities of focus. That includes LGBTQIA+ people, veterans, people with disabilities, and people living in rural communities, which is what we're here talking about today. Also, as we look at the next slide, we of course understand that there is a fair amount of intersectionality among these communities of focus. And I think that you will see that reflected in this Rural Oral Health Seminar series. We can go to the next slide. This session, it will be hosted on our Academy afterwards. Our Academy is the overarching umbrella of all of our education and leadership programming here at AIDPH, and it is also our digital learning space. So we will share links post-session where you can go and find this recording, the slides and resources, as well as information to get your CEUs after this session, and also to share out with colleagues who may want to view it asynchronously. We can head to the next slide. These are our norms, and just ensuring that we come into this space for conversation and interaction, and we're respectful to everyone here. We also want to make sure that we respect patient health information and don't share any personal information from patients in this space. Again, asking you to come on and be on camera and limit your environmental distractions so you can engage and participate with us here today. Can head to the next slide. And also noting, we mentioned CEUs. This seminar is one seminar in a 5-part series that we will be doing throughout the year. We will share information on how you can register for the upcoming sessions. And at the, excuse me, at the, I was sharing in our tech check that the pollen is giving me a hard time. So thank you for your grace. At the end of the year, when we have done all 5 of the series, you can earn a certificate in advancing oral health justice in rural communities by either attending live or asynchronously the sessions and completing competency assessments in each session. We can go to the next slide. And our presenter here today does not have any disclosures. I'm about to hand it off to Bridget, and we can head to the next slide. Before I completely hand it off, I want to get us started and hear from all of you with a quick poll. So my screen, let me just make sure I can find that. As you all know, we're talking about workforce solutions here, particularly in rural communities. And to get us started, we really want to hear from you and what you think about your community. And we would love to know what you think is the biggest lever for improving oral health access in your state. And I see that folks are participating in the chat and introducing themselves. So welcome, everyone. Thank you for taking a minute. Okay, we'll give folks a second. I see the answer is rolling in. I will share it in just a second. Okay. We have about, we're almost at 70%. See if we can, one more second here and get us to 100% of folks responding to the poll here. Okay. Growing the dental workforce is at about 25%, expanding scope of practice, 38%, increasing Medicaid reimbursement rates, 25%. Okay. All right. I'm going to end this and share out our results so folks can take a look at this and do a mental snapshot of where we're all at starting this session here today. And we'll see where we land after we hear from Bridget. So with that and without further ado, I'm very excited to hand it over to Bridget Walsh, who currently serves as a Senior Policy Analyst for Health and Public Health at the Schuyler Center for Analysis and Advocacy, or SCAA. She brings more than 35 years of experience in health policy in New York State, with very deep expertise in health financing, public insurance programs, maternal and child health, oral health, and the social determinants of health. And as we hear from her, I think we'll really see the intersection of her public health expertise with her policy expertise. So with that, Bridget, I'll hand it over to you.
Thanks, Liz. I appreciate it. And I really am thankful for the opportunity to come today and speak not only to this group, but to talk about this report and the work that we're doing here in New York as we try to improve access to oral health coming through the workforce side of projects. Let me see if I can. So next slide. So just a little bit about the Schuyler Center. So we are a statewide nonprofit policy and analysis and advocacy organization, and we work to shape the policies to improve health, welfare, and human services for all New Yorkers. Our particular focus is children and families experiencing poverty, but we're really about policies that improve the conditions in which people can be healthy in New York. Before anybody asks, we are those Schuylers. If you've seen Hamilton, we were endowed originally by the Schuyler family. So we've been doing this work in New York for over 150 years. Our advocacy is rooted in compassion, evidence, and the belief that government should work for the greater good. We achieve those goals through creative and detailed policy analysis, coalition building, and advocacy with elected officials, agency executives, policymakers, and stakeholders. And I think you'll see as we go through this report and the work that we've done, we've hit all those buttons as we've worked our way through this. Next slide. First, I want to thank the funders for this project, including the CareQuest Institute for Oral Health, and then two New York State funders, the Health Foundation for Western and Central New York, and the Mother Cabrini Health Foundation. We really appreciate their commitment to helping us improve the oral health of New Yorkers. Next slide. So this QR code will take you to the website where the report lives. And this is a report I'm here to talk about today. It was completed in February after a full year's worth of work and consideration. We consider it a menu of options for expanding the oral health workforce that's really centered on ways that we can better utilize the existing workforce and also expand the workforce. So I was interested in the poll that just happened because we're going to talk about in the recommendations all of those buckets of workforce opportunities. We believe that the report provides choices for policymakers, health programs, educational opportunities, providers, and also advocates to advance oral health. And I just want to be clear that although we received guidance and input from many organizations, many individuals, all the recommendation in the reports are the Schuyler Centers. We put the report together and we acknowledge all the people that gave us advice and input, and we have asked them all to sign on, and you'll see all their names in there and all the organizations that we work with, but it is a Schuyler Center report. None of what is in the report is new, but we believe we've organized the recommendations into a framework that provides a way to systematically advance policy options. Next slide. Just a little bit of what I'm going to cover today. I'm going to look at the background of the report. I'm going to talk about specifically about 2 data reports we commissioned for this work, a little bit about the report recommendations and how we organize those, and then the work that we're doing now, our next steps. Next slide. To give you a little bit of a background, Schuyler Center has been very interested in early childhood oral health for many years, and we completed 2 early childhood oral health summits. That was the Schuyler Center, the New York State Oral Health Coalition, New York State Head Start, the Governor's Early Care Advisory Council, and we released a set of recommendations for children under 5 to increase access, primarily for preventive services, but we really did look at access to care for young children. And a few of the things we've been implementing this work, but what kept coming back to us when we reviewed all the information that we collected from the summits is that what we really needed to do is start to really look at workforce. It was the hard stuff. We knew it was going to be hard, but we felt that's where we needed to go next. Next slide. And to just give you an example of the sort of feedback we were getting from these summits, when we asked, example for this question, what do programs need to be successful? The answers fell into these buckets. And what became clear is people needed more access to providers. We needed to do more with existing providers. Early care providers need more training on oral health and access to materials and information, but they also needed some place to send young children who needed oral health care. And we realized that if we didn't really tackle workforce head on, we were just nibbling around the edges. There's only so many things we could do without tackling workforce head on. Next slide. So we designed a project, which turned out to be a very big project with a lot of moving parts. But the idea was to establish some work groups, and I'll go through what those were, take a look at data, analyze the data we had in the state, and see what more data we needed, to come up with this report of recommendation, and to meaningfully include the voice of consumers in the work that we were doing, because we really felt that that has been very important, and it was really key to the work that we're doing. But at the same time, to be cultivating those oral health champions in places where we don't usually find oral health champions, and lay the groundwork for implementation activities, because we've done a wide range of educational services during the course of this work. So I'll talk a little bit about that. Next slide. So just give you our components. When we started this work in 2024, we set up 3 work groups. The first work group is the Consumer Advisory Group, and I'll talk a little bit about that separately. The second one is recommendations and strategy, and that would be the people you might call our stakeholder work group. That's about 25 people. We also set up a state agency advisory council. So our health department partners, Medicaid partners, state education licensing board partners, other regulatory agencies were all participated in a sort of a sub-work group that assisted with the work, as we went through this with technical assistance. And then we have what we call the workforce interest group, and that is anybody that wanted to be on a mailing list and attend anything that we did. And we did wind up with we have a mailing list of over 350 people from a wide variety of settings, and they get materials from us. They get invitations to attend meetings and webinars. We've turned in surveys. We've done all sorts of things with this big mailing list of 350 people. So that's our broad interest group that we keep informed. Next slide. And the last sort of, oh, the next slide. It's this one. We did you can go back one. Sorry, I skipped one there. Yeah, that one. And we did 14 educational webinars. I think I missed that one. We wanted to be as transparent as we could and have as much engagement as possible. And so what we said, if we were learning things, we wanted to open up to everybody. If we were going to learn it, you could all learn it. So we did these 14 webinars and one virtual large meeting. We're very, very grateful to all the organizations from around the country who did webinars for us and shared their knowledge on different ideas and models, including AIDPH, who did one on rural oral health for us. And so all of those webinars are housed on our website. Anybody can go back to those and take a look at them. We try to keep them short, 30-minute webinars, give us some information, and then we sort of took it back and put it together with the research and the literature that we were reading as well. Next slide. We commissioned 2 new data reports, and I'm going to go into those in a little more detail. One is specifically on what are oral health needs and what are the consumer barriers to oral health. And so that sort of became the foundation of our research part of this report. I'm going to talk, next slide, I'm going to talk a little bit about the consumer advisory group. I don't know. Liz, do you want to launch the consumer poll to get a sense of who's been working in the consumer area?
Yeah, and I will also just give a note, Shayla, on our slides. I think some graphics aren't populating, so maybe if you, while I launch this poll, you pause your screen share and refresh. I think that will help our graphics show up. Okay. So this is going to ask us if you currently engage in consumer or patient voices in your work. And if so, how do you do that? We're at 69% of participation. And Shayla, if you're not able to refresh, that's okay. I don't want you to be stressed live.
Yeah,
I think a couple of our graphs might be a little wonky, but I'll just note that we'll make sure they're correct in the ones we post to the Academy. Okay. So we'll just see how it goes, and we'll make sure you guys have the correct graphics in the slides afterwards. Okay. All right. 20 of 26 of us have participated, 76%. Give us a final second here. I'll share out the results. Okay. Bridget, can you see those on your end to share out what you're seeing?
Oh, I closed it. Sorry.
Oh, nope, that's okay. I'll share out then. So let's see. So 15% of folks say yes, they formally engage consumers through advisory roles. 40% say they informally engage through feedback, which is really great. 30% say no, but they're interested in doing so also. And 15% say no, it's not applicable to their work. Okay, so that's a pretty good spread there.
So we partnered with an organization called Medicaid Matters New York. That's the graphic that you're missing. And Medicaid Matters is the consumer group, the group in New York that represents Medicaid consumers. And they have a statewide reach. And we partnered with them to find us Medicaid consumers for this project. So the people that we chose are Medicaid consumers. They have an experience with the oral health system, either with themselves or a family member. And they're representative from around the state. We're looking for geographic representation. So we have New York City, upstate, rural. And next slide. And what we had the consumers do is really help us share experiences, their barriers and successes. We really wanted to know not only their experience and barriers, but what they needed. What do they really need from the oral health system in order to overcome the barriers and have better oral health for themselves and their family members? We asked them to review the ideas, and they're New Yorkers, so they didn't disappoint when it comes to asking questions, asking very pointed questions around the work. And I'm going to show you later about how that manifests itself in the report. We asked them to review and comment on the report. We invited them to all the work that we did. We had separate meetings with them so they could engage with each other and with some experts and ask us questions at the same time. So they were integrated in the work and they had their separate communications and their separate work. And then we invited them to tell stories that they wish to share. I mean, there's no pressure to share stories, but if you wanted to share a story, you could. So we are collecting consumer stories. So next slide. So the next part of this work was we really needed more data. And we needed to learn more about New Yorkers experiencing oral health needs. And so we worked with the Center for Health Workforce Studies out of SUNY Albany here at the School of Public Health here in Albany. You may know them as the National Oral Health Workforce Research Center. They just happen to be in Albany, so I'm very lucky that we partner with them on quite a few activities, and we were able to partner with them on this. So I am not a data person, but I'm going to go over at top level, show you about what's in this report. And then I look forward to you all digging into it and seeing what you find. Next slide. So the Oral Health Needs Assessment for New York identifies areas with the highest need for services. And more importantly, it describes what those needs are, what causes the needs in those high need areas. The study is a community-centric approach to analyzing oral health using both social indicators at the community level to provide comprehensive understanding of needs. The thing I'll say about this report is that it got a lot of press when we put it out. It was great for shining a light on disparities and access to care. Not only for ourselves, we got a lot of calls on it, but also the Center for Health Workforce Studies got a lot of calls on it and really answered questions for a lot of reporters who didn't understand access to oral health and the barriers people, the needs in communities around the state. Next slide. So I cannot explain all the methodology, but I will just let you know, these are the demographic and the oral health indicators that the researchers used. They used data sets to pull all this information together. There is a whole webinar on our website. It's in one of those 14 webinars with the methodology, with the researcher who explains how they put this all together. And all that methodology is in the report as well. But these are the indicators that we're focused on. Next slide. And you can see that they broke the state up into these rational service areas. There's 151, and they're based on HPSA designations, but with some other tweaking that they did as well. But so take a look at these numbers as we go, as we advance the work. So next slide. Nope. One before that, there should be another slide in there. There, that one. Okay. That one, yep. High needs oral health areas in New York. They divided those rational service areas into quartiles. They gave them all a number and they divide them into quartiles. You will not be surprised to learn that the blue areas upstate are all the rural areas in upstate New York. And in New York City, the highest need areas, the blue areas, are in the Bronx. It doesn't mean that those other areas don't have need. It just is a percentage based on these composite scores. It's a ranking. The composite scores encapsulate the multi-dimensional nature of oral health needs across the rational service areas, with the fourth quartile identifying those areas with the highest need for oral health services. So out of the 151 rational service areas, 32 were identified as high need. Next slide. Yeah. So and I'll show you the forms in a minute, but the top contributors to unmet need were areas that had the highest disability numbers, lower educational attainment, higher fertility, right, higher numbers of pregnant women, and then the dentist and dental hygiene ratio. So whereas dentist and dental hygiene ratios are very important to those composite scores, they're not the only indicators for oral health need in those areas. Next slide. So I'll show you how the report has these tables in it that every rational service area can go to and find their composite score and identify across that where their highest needs areas are. So if the slide that had all the numbers, right, you identify your need area, you can flip to the table, you can look across this and say, all right, so we have a high score for dentist ratio, dentist ratio, dental hygiene ratio, but we also have a high disability score. We also have a high fertility score. So we can start to, at a community level, tease out how we can address need, not just get more dentists and dental hygienists, but areas where we can reduce need by targeting what is causing the need. So we're working with communities around the state to look at their composite scores and think about interventions that can be done to target where they're having problems, where it's showing up in the composite score. Next slide. So this just breaks it up in a different way, but it turns out that there are over 2.8 million New Yorkers that are living in these blue areas of state, the highest quartile areas of the state. And you can see in some areas, let's say the one I've highlighted there, the Mohawk Valley, they have 6 rational service areas, 5 of them are high need. The North Country, that northern part of the state, out of their 7 rational service areas, 6 are high need. So we can start to look at this data and figure out how we can do community level interventions, but it was also extremely helpful for us at the state level as we're working on legislative priorities, advancing some of our work. Next slide. The other report we had commissioned looked at barriers that consumers are facing, self-identified barriers they're facing, and utilization patterns. And again, if you go on the website, they'll explain all the methodology to this and the data sets that they use to get this. I'm not even going to attempt to try to explain that. But if you go to the next slide. So 2/3 of New Yorkers received needed care in a year. 31% only sometimes or did not receive care in a year. So that's a pretty significant finding in terms of consumer barriers. And so now we can start to match that up again with interventions. Next slide. And you can see here that it is hard to find. Oh,
I think this might be where our graphics are going a little funky.
So, oh yeah. Okay, that's okay. But I will just say that
yeah.
One of the higher needs one, the longest dark blue bar there said it's too hard to find a dentist that accepts my Medicaid. So you can see how significant that was for people who are not accessing care, not being able to find a dentist that accepts Medicaid. Next slide. And again, the second bar from the top, the 21.3% is they wanted more dentists that would accept their insurance. And then you go down a little bar, more dentists in my area. So wanting to have dentists were among the top reasons that would help consumers find a dentist in that survey. So again, this is data we did not have before that we couldn't use. And because of the work we did on this project, we now have all this good data that we can use as we sort through recommendations. Okay, next slide. So that brings me back to the report. So after we looked at all that data, not only here, but the stuff I just showed you, but other data sets as well, we did literature searches, we did researches, we conducted surveys, we held those webinars, and then we started going through all sorts of proposals and recommendations with both our stakeholder group and the consumer group. Next slide. So along the way, what we asked all our participants to look at is to really think broadly. We wanted a diverse range of professions, locations for services, and service delivery models. We wanted an emphasis on prevention, integrated care, multiple access points. We wanted to meet people where they were as much as possible. And we wanted ways to support families and individuals, but also providers and students across the system. We wanted to make sure we were being inclusive when we were thinking about recommendations. Next slide. And so we made maps. We made all sorts of maps. So this is one of the ones that we started with, and you can see this is our equation. We have proposals that bring more people into care, let's say expanding teledentistry programs, expanding preventive care programs, and screenings out in communities, working in primary care offices. They can bring them into the system. And then if you sort through that, some people are going to need treatment, and they will move to the care delivery side. And so we then need to figure out, if you're bringing more people into the system because you've created these better access points, how do we then make sure that they're going to get the treatment that they need, that they've been identified with? And so we're looking at recommendations, sort of bring people in and then making sure that they get the care that they need when they're in the system. Next slide. And we then sort of created this graphic, and you can see that the way we were sort of parsing out the recommendations when they came in is we're looking at, what do you do with the existing workforce? What are your opportunities to expand, retain your existing workforce, and bring in more? And we were looking at both dental and non-dental providers. And then also, what is your new workforce? And what are your options for a new workforce? You can train new dentists and dental hygienists. You can attract them from other places. How do you do that? Or you can create new professions. That's how you get a new workforce. Policy levers, we were looking at a wide variety of things, everything that came up earlier, Medicaid rates, scope of practice, what do the laws look like for allowing people to do things? And also, what is the infrastructure and the data in the state? I mean, how are we creating a way that the work that we're trying to do can thrive as we're trying to expand access? And then we were really thinking about the professional side. We really heard a lot about student debt, recruitment into dental professions, and then making a familiar environment to maybe practice in a rural area, practice in underserved areas, and how do we sort of facilitate that, and where does that fall into the system of workforce? Next slide. So all told, there are actually 54 recommendations in the report, and they're structured around these 4 areas. We believe we need to start by strengthening the capacity of the state to support oral health service, and that is supporting the health department in terms of having an adequate staff and adequate data, so that we have a strong infrastructure within the state. We next wanted to focus on expanding the capacity of existing providers, both medical, dental, and supporting services, people that are already on the ground working in communities. And then we want to increase the number of oral health providers and also provide incentives for delivery of care into underserved communities. So those are their 4 pillars, and where we have allocated the different recommendations. Next slide. So to give you an example of some of the things that are in these buckets, under expanding oral health infrastructure, we're looking at what is the workforce at the health department and in Medicaid for oral health, supporting public health, community water fluoridation, school-based programs, data, and then how can the state help promote medical dental integration? What are the projects and the policies the state needs to have, and the support staff the state needs to have to do that? Expanding the workforce capacity. Obviously, we're always talking about allowing dental and medical providers to do more, really focus on community health workers. That is something that our state more broadly is focused on right now through Medicaid policy. So we're jumping on the community health worker train while it's moving, and making sure we're integrating oral health into that. Increasing incentives and training primary care, expanding teledentistry, medical journal. None of this is new to any of you. I know any of these strategies. Next slide. We had a lot of conversations about dental education, both dental and dental hygiene. Schuyler Center doesn't have the ability or expertise to create a detailed plan of our own for dental professions education and training. But we did at the end of the day come away with the sense that the state needs to develop a master plan using data, using the existing workforce, and developing actual goals and targets for what we need to be training and when we need to be training them and how we do that. And that is, there's a lot of pieces that are already out there, like the loan forgiveness, like training programs, but we haven't married them in a way that actually advances the professions in a systematic way that meets the needs of New York. They're just programs floating around out there that haven't been tied together. So we have put in the report this idea of the state creating a master plan using data to drive the professions forward. Increasing number of providers. Obviously, there's the dental therapy and interstate compact is out there, and then incentives for underserved. Another one that came up earlier in the poll about increasing Medicaid rates, provider technical assistance, targeted financial incentives. So we have a whole section in here just on this. Next slide. So the structure of the report allows us to look at the recommendations in different ways. So we can plan activities in our advocacy. So we can look at all these strategies through a population lens. We can look at them in terms of time, long-term, short-term, medium, and sort of build a network of advocacy activities that can advance the work piece by piece if we need to do it block at a time. So we think those 4 pillars allows us a lot of flexibility, not only for the Schuyler Center to drive the work forward, but we really want to engage in a lot of other partners and players to take pieces of this and to take that work forward. We don't believe it's all our work to do, but we do want to keep everybody engaged in a process of implementation. Next slide. And when you look at the report, I want to point out to you the impact that the consumers had. The report, every section has the big picture piece, and it also has a section why it mattered. The consumers wanted to know, if you did this, what would change for me as a consumer? And then why should I support a policy over here if I don't see an immediate benefit to me? So we could explain how it's a building block for getting them better access later, right? Some of this isn't always direct, it's a building blocks, but we realized that our consumer group needed more explanation on some of this. And a lot of times, a lot of us, we often take shortcuts because we know what we're talking about. We really needed to break it down and explain to the consumers why we were dealing with each of these issues. And then we realized the people that we're working with, the legislative staff, legislators, are also going to need that breakdown. So the report is full of this issue of why it matters. And we think it strengthens the report, and it really shows the impact of the consumer voice in the work. Next. So our main takeaway, and this is not a surprise to anybody, there's no silver bullet, but we have a lot of promising steps to improve access if we take it in a systematic way to address the barriers to workforce shortages. We prioritize prevention, we leverage innovation, and we really work on coordination by the state agencies, the professions, academia, which was very engaged in the process, and communities. That's our main takeaway. Next slide. So what are we doing now? Right? How are we working in 2025? So next slide. So we are looking at the recommendations as we move forward, and we're looking specifically at impact and feasibility as we're analyzing these to figure out which we're going to take on first and how we're going to prioritize these. What is the population reach? How many people are going to benefit from the work? Sorry, I'm in a room with if I don't move, the light goes off. How does it reach the highest need or underserved population? Does it advance equity? How will we know if it improves health access, and what's measurable? Does it align with strategic goals of the organizations that we're working with and the state priorities? Is it sustainable? How can we measure that? Is it cost effective? Does the benefit improve over time? Is it feasible? What is the political and stakeholder support for the various recommendations? What about funding? Is it fundable? Is there already money out there? Implementation capacity. How are our partners and state agencies going to be able to implement some of this work, and what's going to work first and not? Timing and readiness. We all know, if people aren't ready to actually implement something, we got to move to something else and sort of maybe come back to it. So, and what is the evidence base? So here's how we're starting to do this. Next slide. So we chose 5 work groups that we're working with right now that are up and running. 2 are on a population lens, organizing the recommendations around early childhood and the IDD population. We have a lot of experience in early childhood, so that was an easy one for us, and we have had a lot of support for working on recommendations on the IDD population. And we chose 3 specific areas. One, the teledentistry, because New York has very good regulations right now and support for teledentistry. We just haven't really expanded it in a way that gets care out into communities in an organized, systemic way. So we're trying to figure out what are the next steps for teledentistry here in New York to get to those underserved communities. Health and dental providers, again, scope of practice issues, where do we want to tackle? How do we work with community health workers and community dental health coordinators? How do we get training programs implemented? So that's another body of the work. And then the last one, is the community dental health and the dental health coordinators. I already mentioned that the state is already working on community health workers as part of Medicaid. We have a Medicaid waiver that pays for community health workers, so we're really trying to figure out how to leverage that. So a lot of activity with work groups. The work groups are open to anybody that wants to sign up for them and be on a work group. They don't need to attend meetings. If you sign up, you just get materials. You can come to a meeting if you want to come to a meeting. The idea is that by the end of the year, we will have more specific recommendations for the state budget and for regulatory activity and legislative activity to advance the recommendations in these areas. So we're working on that. Next slide. And we do have current legislative activity. Our legislature goes away next week. They're here for this week and next week. We have an expanded collaborative practice dental hygiene bill. It's going to be voted on in the Senate within the next hour. So when I'm done here, I'm dashing up to the Senate to watch them approve the collaborative practice dental hygiene bill. And it's moving in the Assembly. So we're very hopeful for that. We have a bill that came out of work we did on our early childhood that would allow parents to apply fluoride varnish on a telehealth visit. This is something the FQHCs really wanted. We did pass a bill last year to expand who can do fluoride varnish. This piece dropped out, but we have a standalone bill this year. It passed the Senate last week, and it's moving in the Assembly. So we're very excited about that. We think there's a lot of applications in rural areas. This is what the FQHCs in rural areas really want to be able to do. We have a lot of support. Both of these bills are supported by the Dental Society as well as the Dental Hygiene Association. So we pulled a lot of support together. There's no opposition to either one of these bills. Loan forgiveness, there's some bills moving. There's been some activity around some more dental loan forgiveness issues, and we are doing some work around making it easier for foreign trained dentists to practice in New York. So that one won't move this year. We're working on it, but still, for oral health, we've had a pretty good run this year of oral health activities, and we're cautiously optimistic we can get this across the finish line before they're done. Our state budget was 6 weeks late, and that has made it very difficult for us to get some of this other legislation through. But we're we're more optimistic now than we were. Next slide. So oral health project directory, you can find this on our website. We set this up. Anybody can put in projects they're working on so we can each share with each other and find out what we're doing around the state. It's going to help us identify gaps and opportunities for future funding initiatives. That's on our website, and it's running. Next is just the QR code again for our website with all the materials on it. So next is just questions. Sorry, Liz, I get a little long-winded there, but I think I got done.
No, this was perfect. Thank you so much, Bridget. And I think some folks have already posted some things in the chat. The first one from Marla is asking about the state oral health plan, if that would serve as the master plan that you referenced there.
Yeah. Our state oral health plan is about 10 years out of date. We don't have a current state oral health plan. And while we have recommended in our report that the state redo that, I don't think that's going to happen anytime soon. I think it's just a capacity issue. But our master plan, our idea is really around the dental education. I don't know if people know, New York State has 4 dental schools and 2 residency training programs. We have a lot of dental activity in New York. Plus we have 14 dental hygiene programs. But what we don't have is sort of an idea of where people are practicing, how they're practicing, where we're going to need them in the future. How do we organize the benefits and the activities of the state to make sure that we're getting the oral health workforce that we need in the future? There's really no plan for how we're using the loan forgiveness programs, how we're using our AHAC models, how we're using job training programs to sort of help us identify that. So our real plan is sort of, the idea is a master education plan being informed by state needs and state data.
Can I ask a follow-up question to that, Bridget?
Yeah.
Something we had talked about in prep for this seminar that I thought was really great about your materials is I think there's a lot of transferability and lessons learned that folks can take and replicate in their state. Obviously, we're talking about New York State data, but from a process perspective, I think there's a lot of things that folks can replicate. And when you're putting together a report like this, are you considering that capacity piece? You know, ideally we'd have this master report, but that might not be doable. So how do you build that in, but then also ensure that progress can still be made if maybe there's a piece of the puzzle that can't be accomplished, whether it be capacity issues, buy-in, et cetera?
I think that's one of the things that we're working on. It's like, how do we plot these activities out over the next few years? And some of it is going to be, the capacity at the state health department to create something like this. I mean, one of the other infrastructure pieces we put in there is that we're looking for coordination around all the work that state agencies are doing in oral health. Like, do they talk to each other? So oral health is needed in corrections, oral health is needed in children and families, and do those entities talk to each other around the needs, or is it just the health department and Medicaid? And we feel it should be a broader conversation, even if it only happens a few times a year, and that will help us even better understand the needs of populations in New York. And we know there's activities going on in different state agencies, but we'd like to see it better coordinated.
I love that. Thank you. Another question is asking about advice for states who are in need of a state education plan and what should they work on first, or first steps to work towards that.
If you look in our report, we do have some issues and an explanation about all the discussion that we had, because we had a lot of discussion around education. And I finally said, there's only so much. It's not the Schuyler Center, bailiwick to sort of dig into this. But the Dental School Association was part of our stakeholder work group, and they were fabulous. They were wonderful partners in this work. And we have worked with the state and academia on thinking through some of these issues. So yeah, I don't know. We never sort of cracked that nut. I finally had to say, I can't. We have to move on to something else. But this idea that this needs to happen at the state level, I think we're going to continue to push with our agency partners to try to advance that.
Okay, great. Thank you.
I just
And someone else,
part of the reason that we
ahead.
came back to that, just so you know, part of the reason we kept coming back to that is there are a lot of incentives, but they're not coordinated. And so what do you do with these incentives? Well, we need to drive the needs of New Yorkers first. And if the state is going to continue to provide incentives for the schools and students, they need to coordinate those, we believe, in a way that benefits the New Yorkers most in need.
Great, thank you. Another question from Marlo is asking for a little bit more information on the collaborative practice dental hygiene and what that is, and also what provider type is permitted to supervise parents to apply fluoride varnish.
Yeah, the collaborative practice bill, New York has collaborative practice for like federally qualified health centers can do it, but not private. So I don't know if I could answer it quickly. It's just it would allow it's very prescriptive into the settings that the dental hygienist could go to. So it's nursing homes, I think veterans homes, mental health facilities, IDD facilities. It's not every place. It's very prescriptive. And it tells you how many hours of practice the dental hygienist needs to have before they can apply they would be a dental hygiene CP collaborative practice. So it does have a different credential that comes with it. And I work with the Dental Hygiene Association, who knows all the intricacies of it. I'm just, but they did negotiate that bill with the New York State Dental Association last year. So it has been a process here in New York to get the bill that far. So we're very excited about it.
Fantastic.
And the fluoride varnish bill, right now it's dentists or dental hygienists that could supervise doing this. We don't think it's going to be a lot. Because you can't get the fluoride varnish on a formulary, so it has to be mailed. So the idea would be you would identify a family at high need. You would ask them if they want to do this and they feel comfortable doing it. You would set up a telehealth visit 3 months later. You would mail them the kit. You would walk them through a full visit with anticipatory guidance, toothbrushing, nutrition counseling, and then a fluoride varnish. NOAA actually has a training video that shows a telehealth visit with fluoride varnish application. And so we've been using that as our model.
Great. And I was just going to say, I'm assuming folks can kind of poke around. Again, we'll post the slides, and I saw that the bills were listed there. I think something that we find is really helpful is, again, this is state legislative work, but if you have a similar environment or if that's appealing to the situation you have, it can be really helpful to look at those bills and how folks approach them and wrote them to apply to the work you're doing in your state. So I know that folks will be able to dig into those a little bit more. I think,
and
Bridget,
I'm also, if somebody wants to email me, I'm happy to send you everything that we've been doing. I'll share it all out.
Awesome. Thank you. So I think we have about 5 more minutes before we need to close out. And I know you wanted to share a video, Bridget. I think that's enough time. Is that correct?
Yep. Yeah.
Okay, great.
I'm going to see if I can do this. Let me see here. Now I gotta go here. All right, are you seeing that now? Am I sharing the right slide?
We can see it. It's in your notes view, but I think that's okay because it's not video. Maybe if you push, we'll see if we can hear the audio.
All right. So I want you to, oh, that would be bad. How am I not? All right. Because I'm tech challenged, you'll have to watch it in my notes view. Are you hearing it?
I would like to see some type of reform done with more dentists in my area. I don't know about other areas. I know in New York State here we have a shortage of the dentists that takes the Medicaid insurance, and sometimes you got to wait for a month to get seen just for a routine, just to get in, to see a dentist. So and that's not good, because if you have issues, you need to see somebody like within a month, or at least within 30 days, not 6 months or whatever like that.
The feedback from the others made an impact on me, on how, the realities on the ground for them, for the other beneficiaries, and what they see, and something that I learned a lot and it made a difference. It did make me feel more empowered, and just, it made a difference that way, that we can pursue more of a preventive care, that somebody's actually working on that. The work, I think, is critical.
Seemed like many other necessary stakeholders were brought together, first in the same room and then circulating drafts. And there was a definite commitment. And I think I had the impression that it included the state, that something should be done about this, that the prospect of extending the reach of oral health a lot was not beyond the possible. It's not a pipe dream.
Thank you, Bridget. We can pull up our next steps. Bridget, did you have a closing or anything you wanted to say?
I just wanted to show our consumer slides so people can really get a sense of how we worked with the consumers, and how much they really contributed to the work, and they continue to contribute to the work.
Fantastic.
That's our final thoughts.
Yep. Shayla, do you mind progressing to our next steps? As I mentioned at the beginning of this call, we have CEUs available for today's session. We will email out the link to fill out the request for those. I'm sharing our learning objectives here in the chat for those. We will also post the recording. So if there's something you want to go back and reference, if you have colleagues or peers that you think would be interested, please share that out. Also want to share some upcoming sessions. So our next Rural Oral Health seminar will be taking place on July 17th, and I'm posting the link for the registration for that in the chat. We will be hearing from Dr. Nick Rogers talking about disability inclusive dental care in rural communities. So we're very excited about that upcoming seminar. There are also free CEU attached to that session. A few more AIDPH programming pieces. We have our applications closing for our Dental Public Health Leadership Academy, which is a year-long program, fellowship for early to mid-career dental public health professionals. I'm posting a link to that program in the chat if that is something you or you think your colleagues would be interested in. And we are about to open applications for our Federal Service Immersion Program, which is a week-long program that we do every fall in DC, meeting with the federal health agencies and talking about federal health infrastructure and those careers. Those applications are set to open on Monday of next week. If you are interested and want to be notified directly, you can fill out this interest form that I've popped in here. So Thank you again, everyone, for attending and for a really robust Q&A. A big thank you to Bridget and Schuyler Center for being here today. This is really exciting work, a really fantastic model for how some of us in other states can kind of pursue systematic change, workforce development. So thank you so much for doing the work and for taking your time to share with us today. And good luck going and watching that legislative session. Bridget, do you have, yes,
Yeah.
we're looking for your website here, which I
Yep.
think is, okay. At Nevada. Oh, great. Nevada, we heard that you were coming. If you have any follow-up questions, it sounds like you're doing important work as well. Let us know how we can follow up. And if we don't grab, oh, there we go. The link is there. We'll include that in our follow-up email too for folks so everyone has all of the resources. So thank you again. Good luck, Bridget. We look forward to hearing how the legislature goes. And I hope everyone has a good rest of the day. Take care of everyone.
Thank you.